Hi, I'm Lydia Wietzma, and today our podcast, Solving Life's Next Chapter, we have two of our sponsors today that we wanted to introduce to everybody. And we first have Kim Yeatts. She is the VP of Business Development and Director of Business or Patient Advocacy with Savior Hospice and Palliative Care. And then we have Rebecca Rocho, the Phoenix Area Market Director for Dispatch Health Mobile Urgent Care. Welcome and thank you for coming.
Thank you for having us.
So one reason why we wanted to put this podcast together, and I appreciate the sponsors, the one reason why we put this together was mainly because we all work in the senior industry, and what we do is we do a lot of health fairs and we do a lot of seminars, and we try to get with the adult children with their seniors when they have issues. And inevitably, they either don't come to those health fairs or seminars to learn about some of the issues that could happen later on in life, or they come and they don't really get all the information that they need. So when an urgent situation comes, mom falls, dad has a stroke, now we're all in a kind of a flurry as to what do we do and how do we get them there, and they end up in the ER, or maybe they end up in palliative or hospice. So the podcast is really more for getting the information and educating the general public and also the adult children of those that have seniors, and for seniors that are helping other seniors in their neighborhoods. So let's first talk to Kim. Kim, you are hospice and palliative care. And we're going to have both Kim and Rebecca on at another time, kind of more in detail. Today, we just want to introduce you and kind of give us an overview as what you do. So tell us what your company does.
Yes, thank you again for having us. Again, my name is Kim Yeatts, and I am with Savior Hospice and Palliative Care. And we have been in the Valley for many years, but what I love about our company is that we've hand-picked our people. Most of our staff are seasoned. As many of you know, there are many, many hospice agencies in Maricopa County, and you're probably shocked to know that there are over 90 hospice agencies just in Maricopa County alone. And one thing I do take a lot of pride in is that we do handpick every individual of our team. We are kind of in the mid-size company. We're not the largest and we're not the smallest.
Mm-hmm. And you are one of the few that actually have palliative care.
Right.
So explain to us what specifically is palliative.
Yeah, it is a little confusing with palliative because community palliative is not a regulated service or program like the hospice benefit is.
Okay.
So when patients have a terminal diagnosis and they're progressively declining under the hospice benefit, there's certain criteria that they need to have in order to qualify for that service.
Right, okay.
With palliative, it's a little bit looser because it's not a regulated program, if that makes sense. So some hospice agencies do have a community palliative program, some do not.
Right.
Our particular agency, we do have a Medicare certified palliative program in which nurse practitioners, nurses, social workers, chaplains can actually go to the home and get care, even if they're continuing to seek aggressive treatment.
Right.
Even if a great example might be a cancer patient where they're not really quite ready to give up their chemo and radiation because they want to fight their cancer, right? And so in that case,
they need a little bit of services. Yeah.
Yes, they need some support. So that would be a really good opportunity for that patient and family to take advantage of some palliative support.
Okay, gotcha.
Maybe get that social worker involved to assist them with their living will and their advanced directives.
Yep.
And maybe get some home care involved, or perhaps they need placement. They might need to get placement into assisted living community.
Gotcha.
So there are two separate programs.
Right.
There's hospice, which is very regulated, and then we also have pre-hospice, which is otherwise known as palliative care.
Okay, that makes sense. And then Rebecca, you work for an amazing company, and
Thank you, I think so.
give us tell us what your company is and does, and because I have referred a lot of my clients to you, so kind of give us an overview of what your company does.
Thank you. We are a mobile on-site urgent care provider. We're about 6 years old, started in Denver by an ER physician, born out of a 18-month pilot in the Denver EMS system. Dr. Mark Prather, our CEO, actually rode along with EMS and triage patients right on site. So that's how we were born. Dr. Prather is still at the helm. We are owned and operated by ER physicians. We provide urgent care on site. I like to say we can do anything that happens in a standing urgent care with a little piece of the ER.
Okay.
So we can see just about anything in a standing urgent care. We can stabilize a minor fracture. We can treat cold and flu symptoms. We can do ear infections. Just anything.
Stitches.
Stitches, yes. Stitches, staples.
Do you have a machine where if someone needs to, like if they're thinking that they may have a heart attack or stroke?
We have an EKG.
Yep.
So we have a CLIA certified lab. We have an EKG on board.
Okay.
The only thing we do not do is mobile radiology, X-ray, and we bring a third party in to do that. But we can do just about anything covered under the cost of your urgent care copay.
Okay.
So on average, we're with our patients about 50 minutes on site. So I like to remind people, when you're in your primary care office, you may get 7 or 8 minutes with your primary care physician.
Yep.
So nationally, on average, we are with our patients for 50 minutes on scene.
Wow.
Average time to scene could be 1 to 3 hours depending on the day. We're an on-demand service, so we try not to give exacts because it all depends on the day.
Right.
We're open 7 days a week, 365 days a year, 9 to 9. So on the weekends as well.
So what I like about your company is obviously you were created from the medical field and from the ER department doctors that probably saw there was definitely a need for this.
Exactly.
And I have seen you come in your vans, and I tell people that the vans are equipped.
Well, it's actually in our market, it's a Prius.
Oh,
so it's
Prius.
not a van.
Okay, sorry.
It's quite small, and inside each we're a very well branded Prius, and inside each Prius are 7 medical kits, and they're grouped by condition: GI, ENT, ortho.
So it's as though you're coming with an ER room.
Right.
Equipped.
It's just an absolute genius idea. So it's a nurse practitioner and an EMT or a PA and an EMT that typically come together as a team.
Okay.
And then there's always an ER physician who has virtual oversight every day.
Gotcha.
So if a patient wants to speak with a physician, we can call a physician, whoever is there for the day, and have them speak to a physician.
Right. So one thing, my oldest daughter is a registered nurse, and she is neurotrauma. And last winter, we here in Arizona obviously get a lot of winter visitors, and every year our hospitals get very full, and because we're dealing with just the regular residents that live here, but then we also have a slew of winter visitors, which is awesome for Arizona, except if you get sick and you're having to go to the hospital. So last year she said to me, "Mom, we're in Code Purple Phase 1. You need to tell your clients and their friends that if they are sick or if they feel that they have any kind of issues, to either go to a mobile ER department or go to urgent care." And so last year I was referring you a lot because I didn't even know what Code Purple Phase 1 meant. And she said, "Well, we don't have any beds available in the hospital, but we still are admitting through the ER." Well, most hospitals here in the Valley last year had that code, and it always happens every year. So a lot of my resident or clients that I was working with, I would tell them, tell your friends and family, because obviously you work with a lot of seniors, but some of them may also be non-senior related.
We see ages
folks.
3 months to the end of life.
So for you guys, I would think having a mobile ER come to someone's home, or you also go to group homes and
Yep.
facilities?
We'll go to an office, to a soccer field, to
Oh,
wherever you need
wow.
us. We'll go anywhere.
Oh, okay. That's
We're
good.
mobile.
Okay.
So,
That's
yes.
good to know. So if they're being treated more in their own environment,
Yes.
less likely to have
Right.
issues and things like that?
The issue for us, being a new young company, is we're trying to change that habit of calling 911 first.
Right.
So we are working with Surprise Fire now here in Maricopa County to triage patients on site with their crews.
Okay.
So the habit is to call 911.
So
and
what-
people need to change that.
Right.
And we are out there,
Yes.
we're out every day in our community teaching people what is really an emergency, because we want our first responders to be freed up to respond to true emergencies.
Right.
And so it is changing that habit. And that's what we work toward every day, is getting people out of that,
Habit.
that habit of calling 911.
Yep. So when you're working with the Surprise Fire Department, what exactly, give us what the process is for that, for someone if they get called by the fire department?
So if they call the fire department, particularly in Surprise, the crews are going to get on site. They're going to triage to us. So what happens when someone calls us? So we've got 3 ways to access care. You can call us, you can get on our website, or we have a mobile app.
Okay.
So what they'll do is they will expedite that call through our clinical support center,
Okay.
and they do a triage risk stratification. So it's a call that typically takes probably about 10 minutes,
Okay.
because we're trying to find out, number one, whether this is something we can
true
see,
emergency,
or something we need to talk to an ER physician about, or
Okay.
something that needs to go to the ER. So
Gotcha.
we look at
Okay.
it in 3 ways. So we've expedited that process for Surprise Fire, so they will be able to triage quickly on site and leave the patient, let them know with an ETA when we will be there.
Okay, gotcha. So it almost sounds like, because when you work with, not that people shouldn't call 911, but they will get instant
Yes.
care immediately.
Right.
And it may help suffice maybe especially if they're having a stroke or a heart
Right.
attack, and that those minutes make a big difference.
Right. Well, the things like strokes and heart attacks are something that need to go to the ER.
Okay.
So that is what we have, a proprietary software platform that was built by Dr. Phil Mitchell, who has a wonderful TED Talk, if anyone has a chance to see
Okay.
it. It's called ER House Call for the 21st Century. So he built our risk stratification platform. It's his baby. So that's actually how we triage our patients.
Okay. Okay.
It's very efficient, and we have a clinical support center. That's our call center. We have 3. We have 1 in Phoenix, 1 in Dallas, 1 in Denver.
Okay.
So calls route through that. It's typically an EMT on the other end of the phone
Right.
that you're speaking with. They're working through that software
Okay,
platform.
gotcha. And approximately, do you know how many patients you see? I know it was a piloted program out here, but you've now been out here for a few years.
Right. Well, we've just started our pilot program with Surprise Fire. It's
Okay.
just begun.
Just beginning. Okay.
We went back to them because our risk stratification process was a little too long for them, so
Okay.
we went back and actually expedited it for them.
Okay. So is there, hopefully, if that works out, you are going to go to other municipalities and
Absolutely.
Okay.
And municipalities have reached out to us.
Okay.
So
I would
there's
think
a lot
so.
of interest in what we do.
Yeah.
Yes.
So
we have
it-
3 vehicles on the road now.
Okay.
Hopefully a 4th by September. We
Okay.
have 2 that dispatch east and 1 that dispatches west.
Okay. So it's safe to say that if it works out, which I think it probably will, you will end up in Mesa and Phoenix and Chandler and Gilbert and...
Well,
and
EMS is going through a transition. They have they're looking at funding mechanisms through a project called ET3.
oh,
So
okay.
it's something that we will be looking at nationally.
And
yes.
so that's a national...
That's a national
Okay.
initiative, yes.
Okay. So what is probably your biggest call that you get called on? I know that for the seniors, a lot of...
UTIs. So here's the problem
Really?
about the summertime.
Okay.
People do not drink enough water, especially
Okay.
seniors, because they don't want to get up and run to the bathroom.
Right.
Right. So dehydration, that is first of all a terrible problem for our seniors. It
Okay.
could lead to a fall, dizziness, all of those things, but it also leads to a UTI.
Interesting.
So a UTI is something we do very well.
Okay.
It's something we get called on every day for.
Wow. So
during the summer.
So falls are not necessarily your biggest calls. It's more the
I would say upper respiratory, COPD, CHF, and UTIs.
Okay. Wow.
Yes.
Well, drinking water is very important.
Drinking water.
But
We go out and educate in our senior communities on hydration.
Okay. And I know that generation probably doesn't drink enough water anyway because they weren't raised on drinking water.
And they think coffee is water
Yeah.
or iced tea is water.
Yes.
And, my dad is 92 and I have to remind him, your coffee is not a glass of water. Right. It's a constant conversation.
That's right. That's right. Well, so let's talk to Kim, too, about, I know that when it comes to hospice, a lot of people look at hospice as end of life, which it is, but what I find is that a lot of people call hospice too late, and they get on hospice and then they're gone a week or two later. Tell us what tell us hospice is more for not necessarily the length of time, but more the care and it's to make them comfortable during that time of transition. So give us give us the process of it and who calls hospice, or can someone call hospice on their own, or how does that work?
Actually, it's a really great lead-in question because typically people think that to initiate a hospice referral, it has to go directly to the doctor or the doctor. Anybody can initiate a hospice discussion. It can come from your neighbor. It can come from your family. Now, to actually admit a patient onto the hospice program, we do need to have a physician's order for that.
Yep.
But anybody can initiate it. And I think all too often, folks really don't talk about it.
Right.
Because there is still that stigma that hospice is dying.
Right.
And we're giving up hope, and it's at the very end. And actually, statistics show that when hospice is brought on sooner than later, that it actually improves quality of life for the patient.
Okay.
And actually, it lengthens the lifespan.
Okay.
So statistics show about 32 days longer that the patient will live, and they'll live healthier with a more quality of life when they are brought onto service earlier than later.
Okay.
In fact, we get so many comments from families, because not only are we treating the patient on the hospice benefit, but we're treating the whole entire family.
Yep.
But they say to us time and time again, had I only known about this service sooner, because it's a fully covered benefit. So it's not just for Medicare patients.
Okay.
All insurance plans have a hospice benefit in their insurance plan.
I did not know that.
So interesting too is, we think of hospice and we just think about, the 80-year-olds and the 90-year-olds like your father, but actually patients are coming onto service younger and younger because of many different reasons.
Right.
So we actually have contracts with all of the insurance providers, not just Medicare.
Interesting.
Yeah,
I did not know
really
that.
It really is. And it's interesting that the average age for hospice is actually younger than it used to be. It's actually gone down. And so, we have patients that have been diagnosed with a terminal cancer, for example, and they have made a decision not to pursue aggressive treatment.
Right.
And so therefore they just want to comfort and they want pain management, symptom management, and not pursue that aggressive treatment. And actually, quite honestly, oftentimes those patients live longer.
Interesting. Now, I have heard, because some of my clients who have been on hospice have actually gone in and out of hospice. So explain that too, because I think people think once you're on hospice, you're on it forever. You know what I mean?
Right.
Till the end. And that's not always the case.
Yes. And actually, many patients, when they come on, they don't have to sign a contract like they have to stay on for a period of time.
Okay.
It's just the way that Medicare is set up is that in order for them to stay is that they have to demonstrate
Certain things.
a progressive decline.
Right.
But they are more than welcome to come on. They can come off services if
Okay.
they go to the hospital, for example. They oftentimes are actually discharged from hospice.
Okay.
And then once they're ready to go back home or wherever home
Right,
is,
right.
then that's really typically when we bring them back on.
Okay.
Actually, patients, about 10% of patients actually graduate off
Interesting.
hospice, which is
Okay.
really, people think, again,
Right.
that it is truly the very end, but
Right.
oftentimes those patients get better,
Right.
and we have to discharge them off services because they
Right.
graduate.
Right.
They no longer qualify.
Right.
The patients can come on and off services.
Yeah, and what I think I like about hospice that people don't understand is everybody thinks, like you said, it's for the patient that's end of life or going through that terminal sickness. But a lot of times you guys will bring in help for the family, so it relieves some of the stress on the family side of things, correct?
Absolutely.
Yeah.
That is such a huge component. And it's important that when we're providing our service in the home, and again, it's not a place. I think there's a misconception that hospice is a place to go and die.
Right.
And that is definitely not the case. It's a service that we provide wherever the patient is.
Okay.
It can be in a group home, a private home,
Okay.
an assisted living community, so we can bring them where our services wherever the patient is.
Okay, got it.
And that component of treating the family is really important because oftentimes the family is really who
They're-
are stressed out to the max.
I was going to say a lot of times they're probably more stressed than the
Yeah.
actual
Right.
patient
That's
because
right.
the patient has actually resigned themselves and they've gone through their time of they've forgiven family and they've taken care of how they are at peace. A lot of times it's the family that's more stressed out and it's the family that needs probably more of those services than anything. Is that what you find?
That's exactly what I
Yeah.
find. And let the wife be the wife and the husband be the
Yep.
husband and the children, and not the full-time caregivers.
Caregiver.
Right.
And I did hear a statistic, and you ladies tell me if this is not true, but I heard that 60% of the caregivers pass away before the patient.
Oh, yes.
Oh,
Is
They're
that
so-
sure.
because of the
Absolutely.
stress and
We
because
see
of
it
the
all the
physical?
time.
Okay, so that is a true
We have a little
statistic.
80-year-old woman trying to take care of her 87-year-old husband, right?
Yes.
Frail, and we see it all the time.
Yeah.
And I just wanted to say, too, that it's really important for both hospice and palliative care, and that's why we can work so hand in hand with Dispatch Health, is that most of these patients, they really don't want to be going back and forth to
Right.
the hospital.
That makes
because
sense.
actually that's where infections occur.
Exactly.
And actually they're not in the comfort of their own home. So
Right.
we promote wellness when we provide that extra care and support in the home. And also to add to that is that 24/7 nurse line. So yes, we could even contact you all to come to the home, but that 24/7 nurse line, whether you're on hospice or you're on palliative care, is really integral. And we also can provide palliative care and home health at the same time.
Oh, that's interesting.
So-
So how does that work?
Yeah, so oftentimes when patients are in a hospital setting and they're going home after they've had their workup, even if they've broken a hip and they're
Right.
going to rehab, and then from rehab they're going home,
Right.
they typically go home on home health.
Right.
And that's a good time to actually bring in the palliative services.
Okay.
Because typically home health is pretty short term.
Right.
And there's some plans that actually limit their
How many
physical
hours they
physical
can be there.
therapy visits to 3 visits. And so
Okay.
it's nice to be able to have that adjunct to palliative as well, especially for those COPD, CHF,
Okay.
Infections, stroke patients.
Okay.
So there's a lot of that extra support that can be provided to the home
Right.
with palliative care and home health care at the same time.
That is very interesting. I have never heard that from anybody, so that's actually good
Yes.
information. So, well, we are almost time's up now, so I really appreciate you both coming in and talking to us, and we will have them both in on a separate time for a 30-minute, because obviously palliative and hospice is much diving deeper into specifics. And then Dispatch Health, who is a mobile ER, they will come to your home so you don't have to go to the hospital. They have some great services and some good information and tips and tricks on how to keep yourself healthy and not have to go to the ER or have to have them come to help out. So I really appreciate not just you being here, but also being the sponsors of our podcast of Solving Life's Next Chapter. And we will have both Kim and Rebecca back at a later date. So thank you so much, and thanks for coming.
Thank you.
Thank you so much.